Right, well, we're going to talk today about ME, chronic fatigue syndrome, having had some introduction from long COVID. And I'm going to talk about whether they are in fact very similar or the same thing. And we're going to start off by talking about making a diagnosis of ME, chronic fatigue syndrome. ME standing for Myalgic Encephalomyelitis. Well, what is it, and are they the same as long COVID? This is an illness that's usually triggered by a viral illness, of which, of course, COVID would fit that picture. And there is genetic vulnerability. There have been twin studies and family studies showing that there is a trend to inheritance of getting the condition. And it's a condition that's due to persistent overactivity of the immune system, accompanied by some brain inflammation. Activity of the microglia in the brain cells is very evident. There's an upset in the underlying body biochemistry, imbalance of the microbiome, which of course we now identify as part of the immune system. And this all leads to a variety of symptoms, which can be very different in different people, but the symptoms often mimic the initial illness. For ME, the prevalence is around between 0.5% and 1% of the population, which would equate to probably 20,000, 18,000 patients, 20,000 patients or 18,000 patients in the population, not all at once, and some may be very mild and some may be very severe, needing total care and being bedridden and even needing tube feeding. The less ill people are able to continue with work and school, and all age groups are affected. I've seen children as young as 4 with this condition, right through to the very elderly. But making a diagnosis in those extremes of age is very difficult because of the obvious issues of other illnesses, and of course in children, difficulties with communication. The illness is tending to be more common in females, and it is thought there are some hormonal links. Predisposing factors, well, we've mentioned the genetic predisposition. There will often have been mental or physical distress in the lead up to the illness, particularly things like over-exercise or an accident or surgery. Some question of whether immunizations can be a trigger, and many patients will have experienced a sleep deficit, people like shift workers and young mums with new babies, but the most likely trigger is some form of viral illness, particularly characteristically infectious monoglandular fever, and now we are looking, of course, at COVID. A typical scenario, the illness occurs with an acute episode of viral illness with immune activation, and probably over the first month, 90% of patients affected will be recovered. So the immune system quietens down. About 6 months of post-viral illness, post-viral phase, which we're, I'm sure, all very familiar with, again, gradually improving over that time towards complete recovery. But at 6 months, there will still be, following infectious mono, about 1% of patients still unwell with an ongoing post-viral condition, and a little bit up and down depending on levels of stress and activity and pressure. But the length of time of the illness is a total unknown. Some will be improving, getting better, but many will remain ill for a very, very long time, maybe even lifetime. And typically, a sports person is a very vulnerable person. This doesn't mean that all sports people could be at risk, or that all people who develop ME have been sports people, but that's just an example of a typical person who is pushing the body hard, under a lot of pressure maybe, and then getting a viral illness from which they don't seem to recover. Main symptoms, fatigue for sure. Post-exertional malaise is characteristic in that the person often wants to get back into activity, but finds that they relapse very readily if they push the boundaries beyond simple levels. Most people will have cognitive problems, often the main reason people can't get back to work. There will be a tendency to dysautonomia, which we call POTS, and flu-like symptoms frequently recurring. Many people will have pain, fibromyalgia, headaches, gut problems, and typically pretty well everyone will have some form of sleep disturbance. Because many GPs, and I was the same initially, lack knowledge about this illness. It's not something that's taught at in medical school very often because it's not a very common illness compared with the usual hypertension, diabetes, and so on. And most GPs can only offer a 15-minute appointment. And obviously, if you know this is a likely possibility, encouraging a longer time slot if you've got the time or if the patient can afford to pay. The GP needs a simple checklist. Often this would be one that they've downloaded or in advance, or which maybe the patient brings along. And there are various sets of diagnostic criteria which have been put out over the years, but the one that I would recommend in general practice is the one produced by the Institute of Medicine, which is quite a short checklist, and you should be able to download that after these presentations. The patient needs to have available afterwards suitable handouts, so that's again something that could be available at the surgery or online. And the patient must be encouraged to stay on track because they've often got so many symptoms and such a confusing story that it's very, very hard to pin them down. And of course, follow-up is always needed. Making the diagnosis is the usual way we do it, looking at the history carefully and a simple examination, checking for lymphadenopathy, blood pressure, and watching for hyperventilation, which frequently goes hand in hand with this illness. There's a lean test put out by NASA, which is useful for checking for dysautonomia. And again, these things should be available online quite readily. Ideally, the patient should have had some lab tests done before the appointment if you know this is coming up as a likely diagnosis. And these lab tests are mainly exclusionary to make sure there are no other overlapping or alternative diagnoses. A brief assessment of mental well-being is usually possible during the consultation, watching for signs of depression, anxiety, and so on, and sticking to a set of recognized criteria if possible. The core symptoms are post-exertional malaise, sleep deficit, poor cognition, pain, and so on. And we need to always look for overlapping conditions, POTS, Ehlers-Danlos syndrome, fibromyalgia. These symptoms are common and may be related to other conditions, which means that the diagnosis may need to be looked at by specialists or further for sure. But if the patient gets a diagnosis, even if it's a tentative diagnosis, this creates enormous feelings of relief and a sense of being in a team, ready to take on the treatment suggestions that you may be able to offer, and certainly the support and guidance from other health professionals, maybe within your practice or that you can refer on to. So following on from making a diagnosis, we're now going to talk about how we manage ME, chronic fatigue syndrome. And I think although a lot of this session is going to be focused on long COVID, because there is now such a likely issue that long COVID and ME are probably the same thing, another post-viral syndrome. The management strategies for ME are really very much the same as they should be for long COVID. I think the difference is with long COVID, we are looking at sometimes specific symptoms due to damage from the actual viral illness that the patient has experienced. So one might need to focus on those specific issues and treat accordingly. But making a diagnosis, as we've just said, this is how we would do it in general practice, and hopefully at the end of the first consultation, or if it's a long consultation, maybe halfway through, one is ready to move on to a treatment plan. And I usually say to the patient right from the word go, I'll give you everything written down. And this means hopefully they're not going to sit there scribbling away, whereby you lose eye contact and communication is affected. And also, because you're going to give them everything written down, they really don't need to write down an awful lot. I think during the consultation, planning for treatment is important, and there may well not be time to do many of the things that I'm going to say now, but at least if the patient can be brought back for a follow-up appointment, some of these issues can be focused on, and some more importantly than others, depending on the particular personality, age and style of the patient, and of course of the doctor as well. There should be first and foremost attention to mental well-being, because as we know, anxiety, depression, all these things are going to affect one's ability to cope with a serious illness. And so talking about things like music, meditation, yoga and so on can be a helpful start. I think it's important to stress to the patient that you're not, as a result of all this, labeling them as suffering from a mental illness, but that every illness is helped by attention to mental well-being. Even a common cold you recover better from if you're in a good mental state. We then move on a little bit to exercise and the importance of the cautious approach, pacing very carefully and never pushing the boundaries beyond one's comfort zone. Post-exertional malaise occurs so readily, and if pushed hard can lead to serious relapse, particularly in people who are sporty. Diet, well, important to have variety and a good diet, little and often, plenty of variety. And for most people who have with this illness a tendency to dysautonomia, plenty of salt. That is really important at helping to keep the blood pressure within a normal range, which tends to drop away very readily on standing or hot temperatures and so on. And I'll talk about a bedtime snack in a minute and the importance of that. Patients often want to know a lot about supplements, but there are really not many that have much help in this condition, and they should be encouraged to save their money where possible. Maybe some help from magnesium for cramps. CoQ10 can help a little with cognition. B12 injections, yes, have been shown in research to be useful. The research came out of Iceland some years ago, and high homocysteine levels have been found in the cerebrospinal fluid, which means the B12 level can be quite low in the nervous system. And B12 injections can certainly help. Probably 50% of patients will feel some improvement, particularly cognitively. Vitamin D, useful for those patients who are constantly indoors because of the illness. We need to look at hormonal issues, the illness being more common in females than males, and oral contraception is certainly very appropriate with estrogen for younger women and hormone replacement for older women, and looking too at iron levels because often the periods have been very, very heavy. But certainly estrogen has been shown to be useful in many patients with this illness. We obviously can't give it to men. Pain management important because pain does have major interference with one's ability to enjoy life and even do daily chores. Sleep hygiene is really important, and I found that the majority of patients I was seeing had a very poor non-restorative sleep pattern. So looking at the sleep issue is very important. And there's some research came out from Finland. Markku Partanen is a sleep researcher, medical person there. And he talks a lot about the orexin system, which is part of the sleep system, and finds that if the orexin levels in the brain are low, you get better sleep. And the way to decrease orexin levels is to have higher level of glucose in the system at bedtime, and this leads to feeling sleepy and chance of a better sleep. And so a snack at bedtime has been shown to be very useful, and this should be something with readily available glucose in it. Other medication, not just for sleep, but for management of the illness generally. We do need to look at sleep management. Melatonin has some questions over it in recent times, but some patients do feel that they're helped by it. More commonly, the tricyclics, amitriptyline or nortriptyline, needs to be taken 4 or 5 hours before bedtime because everything's very slow to kick in, and needing to treat with a very small dose, starting at about 5 milligram, building up gradually over time, and telling the patient it may not kick in for a week or two. Promethazine handy. It is very sedating and a useful antihistamine for those who have a lot of problems with allergy. You can combine some of these things if the doses are very small. And simple anti-inflammatories, simple Panadol, things like that for pain management, muscle relaxants such as orphanedrine, and certainly moving on to heavier pain management if one needs to, though often the tricyclics are a good starting point. Hormones we've already mentioned, allergy, important allergy control, and fludrocortisone, very useful for those who have serious problems with POTS, about 0.1 milligram daily in the morning, and any obvious infection which may be stirring the immune system further should be treated with either antibiotics or antivirals. Often a herpes infection may be recurrent and may have even been the trigger of the initial illness. So longer courses of antivirals are often very useful. Should involve other personnel as well, and obviously some of these people may be available at your own clinic, but certainly physios, breathing help, dealing with psychological problems, even budgeting and home help, really important, and referring on to specialists for neurological or rheumatological evaluation if need be. And obviously having handouts available online, really important for the patient. Again, it gives them credibility. They feel that you're really recognizing their illness, and also something to take away so that, again, they don't need to sit there making endless notes. Follow-up, really important, and I usually say, well, we'll start with this simple plan and see how you go at about 6 weeks. Ideally a longer consultation because there will often be many, many questions to be asked. May be necessary to then follow on with further lab tests and x-rays or what have you, depending on symptoms. Dealing with which symptoms are the most troublesome is the best approach to make, and not forgetting the daily routine smears, mammograms, etc., which tend to get lost in the mire of all this illness. Looking at other options, people are often interested now, patients and other doctors I've spoken to, in whether LDN or low-dose naltrexone can be used as a medication which can be very helpful. The work done at Griffith University in the Gold Coast has shown that there's abnormality in the receptors that control the movement of calcium in and out of the cells, particularly the natural killer cells, and this can affect every system in the body. And it's may be yet to be further proven, but certainly the research is ongoing and looking very promising. And low-dose naltrexone corrects this abnormality in the calcium channel mechanism. And it's an issue that can be discussed. Again, handouts about low-dose naltrexone for the patient. They may already know quite a lot about it because these patients inevitably spend a lot of time online looking to see what's possible. Before prescribing it, it's important to familiarize oneself as much as possible with it, checking other medication that the patient may be on, because naltrexone typically is used to help people get off hard drugs in much higher doses, of course. So we need to be careful that there are no conflicts there. And the low dose that we start with is very, very tiny, 1 milligram. It needs to be prescribed probably through the local chemist, who can then access it through a pharmaceutical compounding company, or as a GP you can get it direct or send the prescription direct to them. Some patients do have insomnia on it, and so best to start their dosing in the mornings, so that if they are going to get insomnia, they're not going to be awake all night. If, however, they happen to feel sleepy all day on it, then they will be one of the smaller percentage of patients who are better to take it in the evening. Persevering is important for the patient. It can take about 6 weeks to show benefit. And one of the downsides, of course, is cost. Some patients don't respond. I found probably about a third of the patients who get put on this do quite well. About 1/3 will say did nothing for me, and about 1/3 may get some side effects that they may not feel they can cope with. Important too to communicate with their other providers, and again, information sheets should be available. Part of the ongoing follow-up consultation, often patients are going to ask about things like pregnancy. Pregnancy is not necessarily contraindicated except in those patients who are very sick, and often delaying the pregnancy is wise, and that would be particularly so, I think, after long COVID. But generally, the hormones the woman produces in pregnancy, estrogen particularly, have some positive benefits on pain and cognition and sleep and so on. Other treatment options can be discussed, and these are many and varied. I have lists of possibilities. Things like mestinon, which we use for myasthenia gravis, has helped some people. And, there are many, many other options. And a lot of people want to discuss immunization, particularly the ME patients are worried about COVID vaccination, and there have been some reports of nasty relapses, though I've also had reports of patients who feel they've done very much better after an immunization. So it's a little bit of an unknown, and we don't really understand enough about it as yet, but these things need to be addressed. I think ideally this illness and long COVID should be managed in general practice. Getting specialist appointments these days is very hard anyway, and not many specialists know an awful lot more about it than the average GP, who is at the front line and knows the patient really well. The plan can be very simple, and the patient has confidence and a feeling of knowing the GP, which makes a huge difference, to give them better outcome from the consultation. If the patient's been referred to you by someone else, maybe the physio or naturopath or another GP or specialist, it's obviously important to report back to that person, because that's a very useful educational tool for them too. And I found also that often getting other GPs in on the consultation is really good. Again, someone to discuss things with afterwards, and certainly your local peer group can be a very useful opportunity too. So I hope this gives you some simple tools to start the process off anyway, and thank you for listening.